I'm Jason. I am a current med student, started my third year at Northwestern in Chicago. I'm originally from Michigan. I went to University of Michigan. I'm also a USABO alum. I was a national finalist, I think in 2018, 2019, it's a long time ago. Went to IBO in 2019 in Hungary, was a silver medalist there, and I've TA'd a couple years back. But yeah, happy to meet everyone virtually. I'll be talking a little bit about histology as well as animal phys. Okay, so we'll start with histology. I've given this lecture a couple times. Essentially, I'm not going to spend too much time on this since a lot of it is just looking at pictures. A lot of it's like pattern recognition. And they'll send out these slides later and you can kind of like go through it more in depth on your own time if you'd like. So I will probably kind of speed through this a little bit, but if you have any questions, if you want me to slow down, just let me know. I'll be happy to talk more about it. All right, so histology and histopathology, this is where we are looking at cells under the microscope and we can determine whether the cells are normal, abnormal, a lot of applications in the medical field. And this does come up. I know like we like to test this at national finals. It does come up at the IBO as well. So I think it's generally just good to have like a general understanding of just basic histology. So I'll just go through some concepts here. So let's start with some staining methods. So these are unstained cheek cells. You might have done this in like your high school bio class. And if we really want to visualize like intracellular structures, we want to stain these things. So there's a couple different stains that we use. The main like workhorse stain is the H&E stain. So if you go to a pathology lab, this is the first thing they'll do. This is fast. You can do it in probably like 5 minutes and you get pretty good visualization. So this is the combination of two things, hematoxin and eosin. So hematoxin, this will stain your acidic structures blue. So this will mainly kind of highlight the nucleus, and this will be a basic or cationic stain. And you counterstain with eosin, which will stain everything else pink, mostly the cytoplasm, basic structures, and this is a acidic stain. You also have the toluidine blue. This is used for in like kind of plant applications. You can stain like polysaccharides. This is used for like staining things like nerves. So on the right, there's like a big nerve bundle there. You can use it to stain mast cells. And the Golgi stain, this is like, I think you use silver nitrate or silver chromate. And this like kind of randomly stains some of the cells in the slide. So this is good for like really dense slides like neurons. This is usually what they use the Golgi stain for. So this is kind of a black and white. It'll show us these like dark stains. You have pearl's Prussian blue. This is mainly iron stain. So this is useful for diseases like hemochromatosis. If you want to look at like liver biopsy, you want to see if there's like iron overload, this is what you would use, pearl's Prussian blue. And how it works is it reacts with ferric iron, and this will form a pigmented deposit within the cells that shows up as blue, and you like counterstain it with like eosin or something. And then some blood stains. So these are generally grouped as Romanowski stains. And some examples are the Wright stain, Giemsa stain. You might have come across these if you're been studying like blood cultures or blood smears. So these are usually the combination of eosin as well as the methylene blue. Usually like you kind of see this pattern where like when we're staining cells, we have a basic dye and an acidic dye. So we get like good kind of visualization of acidic nuclei as well as cytoplasm. So here's the right Giemsa stain. Someone want to tell me what the cell on the top left is?
Neutrophil.
Okay, great. How about the bottom left?
Monocyte.
Okay, great. Okay. You guys have a good handle of this. Okay, and then IHC. This is really useful if you want to stain a specific protein. A lot of pathologies will, like for example, if you want to see like neprilysin in the kidney, you can stain for that. So this is essentially like kind of like I think of it as like a Western blot, except you do it. It's like basically the same process of Western blot, except the secondary antibody you have like a color product. So then you can use it to visualize specific proteins. And you can understand with like hematoxin. So this is what it looks like kind of on the slide. On the left is a kidney stain where you stain for neprilysin. On the right, I think this might have been one that I did a long time ago. This is we did like a keratin, some sort of keratins were staining for like long epithelium. So this is good because it highlights the presence or lack of protein. So a lot of like question stems, they might give you an IHC, they'll tell you what it's staining for, and you can use it to figure out like what disease process it's trying to represent. Immunofluorescence, pretty much similar to IHC, except for secondary antibody is something like a fluorescent antibody. And then you'll counterstain with like DAPI, which stains the nuclei blue. And this is what it looks like, very colorful. And yeah, I think on the right, this is showing like Zika, where they stain for like the Zika infected cells. We're using an antibody for the Zika protein. Okay, so there's a lot of different types of stains. Like I wouldn't like try to memorize everything. I think that's just like generally have an idea of what staining methods there are, like what you would use each one for. But yeah, so generally for histology, some general tips that I tell students are that you want to learn like, so when you get an image and they're like, what is this or what disease is this? What like I think it's helpful is you break down the image into parts, try to identify different like sections of it separately rather than taking in the whole thing at a time. Another thing that's really important is when you like practice with images, make sure you're not memorizing the images, because that can be something that's easy to do, especially with like a small image bank. So you really want to memorize patterns or like specific structures and not like memorizing the image itself. And also like be careful about color. Sometimes colors can be helpful, but a lot of times like if you have a different stain, you have, different lighting, it'll look different. So if you're relying on color a lot, that may cause problems down the line. Okay, so very brief overview of types of epithelium. And this is really useful because like I think the first thing I do when I see a slide is try to identify if there's epithelium present and if so, what type it is, because that can inform you about the function of the tissue you're looking at. So for example, if you see a lot of like flat layered cells like this, a lot of them are lacking nuclei, that might tell you that it's stratified squamous. And some places where you'll find this are places of the body that are exposed to high levels of like abrasion, so skin esophagus, oral cavity, things like that. Simple squamous, this is good for diffusion layers, for example, in the alveoli and the capillaries. Pseudostratified columnar, this will sometimes be ciliated, sometimes not. Technically is a single layer, but because of like the staggering of the nuclei, it'll appear kind of multi-layered. So this is in places like the trachea, epididymis, prostate vas deferens. And in simple columnar, this can also be ciliated or non-ciliated. So this will be like upper respiratory tract. A lot of parts of the GI tract will have columnar epithelium. And then cuboidal, I think cuboidal epithelium is really important to be able to recognize because that will actually tell you a lot about the function of the organ. So these are a lot of like secretory organs will have cuboidal epithelium, such as kidneys, ovaries, thyroids. So that's something that you should be able to recognize. And finally, transitional. This is a little bit harder. I think there's like these little like umbrella cells, like over here. But also like transitional epithelium will present differently whether like the organ is distended or not. But essentially this is like a lot of parts of the GU system that need to be able to accommodate fluid, like the bladder ureters will present with transitional epithelium. Okay, and then oops. All right, and then just like kind of generally going through some different body systems and what it looks like under the microscope. So for bone, depending on like what type of bone it is, if it's compact or spongy, it'll look different. But usually you'll see like these concentric like whorled systems. So like in the center, there'll be like an osteocyte. You might be able to identify osteoclasts, osteoblasts. You can see red marrow. And for cartilage, I think you should be generally familiar with the different types of cartilage, the hyaline, elastic fiber cartilage, and also just like know what parts of the body. So what parts of the body you'll be expecting to find these things. For blood, I think you guys are pretty good with like identifying different blood cells, but just be able to identify, different white blood cells, red blood cells from like a blood smear. And okay, so moving on to arteries. So what just a question for you guys. What type of epithelium do you see in this image? Or would you expect to see?
Simple.
Okay, I didn't quite hear that, but if you said simple squamous, that is right. So the lining, the tunica intima will be made of simple squamous. And then arterioles and venules, same thing, you'll expect to see simple squamous. And I think it's sometimes a little tricky to differentiate between like arterioles and venules. And usually like I think like a good thing to go off of is just like the thickness of like the mural layer, the muscle layer. And like on the image on the left here, this is pretty apparent. Like the venules, like you can see the muscular layer is like a lot thinner and versus the arterial. But sometimes the venules can be pretty thick as well. So it's good to just like look at some more images and try to identify those things. Capillaries, these are either like whether you get a transverse or longitudinal view, these will look differently. But capillaries are usually pretty easy to identify. They're just like very small and they usually will have blood in it, hopefully. And then looking at veins, something else to look for is like if you see valves, that's like pretty indicative of like it being a vein, since you wouldn't expect to see that in an artery. So if you do see that, that's like that'll be very helpful for helping like identify what you're looking at. And yeah, just like be aware or be familiar with like the different layers of of the veins or the arteries. Okay, here's kind of a view of everything. Vein versus artery. You can get some pretty muscular veins as well. So it's generally just, I think arteries are, the lumen will be a lot more circular than the vein. The vein was more compressible. That's like a big thing to go off of when kind of trying to differentiate between these things. Okay, so moving on to adipose tissue. Adipose tissue, I think, is pretty distinct. Just like kind of look like these big fat droplets with the nuclei sequestered to the edges. I think this is pretty straightforward to recognize. Skeletal muscle, I think you should be able to differentiate between different types of muscle fibers. So skeletal muscle, you'll see like striations, they'll be multinucleated. For cardiac muscle, what you're looking for intercalated discs. There also cardiac muscle is branching, so you can see there's like a branch here. There's like a little branch here. And usually there are like less nuclei that you'll be able to see. And then smooth muscle, this is not striated, and a lot of times you'll be able to see two layers. So there's like a longitudinal and a circular layer. So this allows for 2 degrees of movement. So if you're trying to compress like the GI tract for peristalsis, this is why smooth muscle is present there. And then the brain. The brain gets tricky because there's like so many different parts and it like all looks very different. So I think just generally with like histology and pathology, the best way to do is just like look at lots of images and be comfortable kind of recognizing where you are. So these are some pretty clear-cut images of brain because you can like literally see the neurons. And you can see some astrocytes here forming like the blood-brain barrier. And here are some peripheral nerve fibers. So these, I think peripheral nerve fibers and like smooth muscle can like look very similar. So I think again, just like practice, but usually like smooth muscle fibers, they're like a lot more densely packed. You see like this peripheral nerve, this like longitudinal cut, like there's like some more spaces in between. And yeah. Okay. Some different parts of the brain is like cerebellum. If you see these big neurons, these like big Purkinje cells, that should tell you that you are in the cerebellum somewhere. And then different parts of the pituitary. Pituitary can get kind of tricky as well. And this is another one where it's like important not to memorize color because you see on the left here, like the anterior pituitary is like kind of red. But then the top right images here is like kind of more purple. So you can't really go off of like, you shouldn't remember like anterior pituitary is like lighter color than posterior. And then different layers of the eye. I think the eye is pretty distinct. Like you'll be able to see like rods and cones, like different layers of the like different nerves. So usually this is like pretty straightforward. Same for the ear, it's like very distinct. You can see like the cochlea, the different layers, endolymph, perilymph, and the organ of Corti, which is pretty cool. You can see like the hair cells there as well. Okay, so thyroid, epithelium, what do you see here?
Cuboid.
Yes, exactly. Cuboid epithelium, and that should tell you that we are looking at a secretory organ. So the thyroid obviously produces a lot of hormones. So it makes sense that a lot of it is made of cuboidal epithelium. And then the parathyroid here, it'll be kind of interspersed within like thyroid tissue. And you have oxyphil and chief cells. So does anyone know what chief cells are used for in the parathyroid? I think I heard parathyroid hormone. That is correct. That they secrete parathyroid. And then oxyphil cells, I believe they still haven't quite figured out what they do, but they are kind of more a little bit more eosinophilic, and they're really interspersed within the parathyroid. Okay, adrenal glands. This is like a terrible image, but adrenal glands, you'll see like there's 3 different layers of the cortex as well as the medulla. So someone tell me a hormone made by the glomerulosa. Okay, perfect. How about the reticularis?
Androgen.
Yeah, androgens, DHEA, which is a type of androgen. And the fasciculata is mixed cortisol. Very good. And then, yeah. Cool. And then there's another layer. Sometimes it's kind of hard to differentiate, but I don't think like for your practical and theory, like I don't think they'll be mean and just like zoom in on a tiny part of this and be like, what layer of the cortex this is. So I wouldn't like worry too much about like differentiating between this, but I think generally just like know where different hormones are secreted. It's probably the most important part. And okay, so the pancreas, someone shout out some types of epithelium that you see. Okay, so yeah, so you see some cuboidal here. We also have sometimes columnar. And for the pancreas, like it's important to differentiate between the exocrine and the endocrine pancreas. So you have an islet here. We're making your insulin, glucagon, somatostatin, and then have pretty much everything else is exocrine. And you'll be able to sometimes see ducts where the pancreatic exocrine secretions go. You see like an arteriole here, probably like a venule. I think pancreas is pretty distinct as well, so should be one that you're comfortable with. And okay, cool. Okay, lymph nodes. This also gets kind of crazy. There's a lot of different parts, but someone tell me what the function of the germinal center is.
Cell proliferation.
Yeah, so it's B cell proliferation, differentiation. Lymph nodes are also like I think pretty easy to differentiate, pretty distinct. Like the big you're looking for are germinal centers. As well as like the cortex where like the T cells are living. We have like some medullary cords going into the center. So I think like generally just like main thing is just like know what a germinal center looks like. And you'll see this in other like immune organs as well. And then here's the spleen. Also immune organ. So someone told me what the white pulp does. Okay, so yeah, so it's for also just immune function, like where T cells, B cells can encounter antigens and become activated. And red pulp is where a lot of RBCs get processed. And here's the thymus. Thymus is also pretty distinct. So just like note like pretty much for all these slides, the general takeaway is just like be able to recognize like what organ this is and know functionally like what it does, and especially like different cell types. I think like that's probably the most that you'll be tested on. And this is a Hassel's corpuscle. I think also they don't really know what this is, but it kind of just like lives in the thymus and the medulla. Okay, so you're now moving on to lungs. Okay. Anyone know what type of epithelium bronchioles are lined by? Okay, so it's simple cuboidal. And how about the alveoli? Yeah, simple squamous. So again, function-wise, the alveoli are for gas exchange, so it makes sense that they're simple squamous. And I think type 1 and type 2 pneumocytes, this is important to know. So what do type 2 pneumocytes secrete?
Surfactant.
Okay, great. You guys are ahead of this. Okay. So now we're moving on to the GI system. Some of it can look pretty similar, so I think you should be comfortable with differentiating between stomach, small intestine, large intestine. So for the stomach, so all layers of the GI tract will have the mucosa, submucosa, serosa, adventitia. For stomach, some things you're looking for are like gastric pits. And these contain like the parietal cells, the chief cells, stem cells will be at the bottom. And I think that's the main thing to look for. And compared to like the like crypts in the large intestine, these like won't go as deep. And you'll see some like glandular structures here. That's something to look for the stomach. And I don't think this is that important. Small intestine, so you'll see villi. That's something that's like you'll be looking for small intestine, and also these crypts that go pretty deep, they're pretty thin. That's what usually I look for the small intestine. And then the colon, kind of just visually, I feel like this, like if you look at the, oops, like you can see like very distinct villi for the small intestine. And then for the colons, like the ends are like a lot more blunted. And then you'll still get these like kind of deeper crypts with like goblet cells and producing a lot of stuff. But just generally like look at images, be comfortable with differentiating between these different things. And okay, so let's move on to the liver. So the liver is one of the portal systems in your body. Someone want to tell me what another portal system is?
Both pituitary.
Yes, exactly. I don't know who said that, but pituitary is also a portal system. And the main thing with the liver is you should be able to recognize the portal triad and identify each part of it and know what it does. So you have the portal vein is coming from GI tract carrying nutrient-rich blood. You have a hepatic artery that is carrying oxygenated blood into the liver, and you have a bile duct that's carrying bile to the gallbladder. And then usually you have like a central hepatic vein in the middle of your lobule. So the liver is divided into these functional like hexagonal units, and yeah, it has a lot of functions. Just be generally familiar with what it does. And gallbladder kind of looks, there's a lot of these like extensions, just maximizing surface area. I think not too much to speak on about this, just like be familiar with what it looks like. And for the kidney, let's see. Okay. Someone tell me what type of epithelium the PCT is made of? Parietal tubule. Okay, so yeah, PCT is cuboidal. Sometimes it would have a brush border, so we see some microvilli. And then the loop of Henle will have like simple squamous epithelium. Let's see if we can find on here. This might be like a little loop of Henle, but and usually like for these ones, sometimes it can be hard to differentiate between like the capillary or blood vessel versus like a loop of Henle. So you want to look for it. Sometimes you can see red blood cells inside, which will tell you that it's a blood vessel. And then the collecting duct is usually cuboidal or columnar. All right, so this is some collecting duct cuboidal. You see like the loop of Henle here, thick and thin segment. All right. Okay, so some quick review. What is this pointing to? Okay, I can't really hear people in the back, but this is an islet in the pancreas. I don't know why it says kidney there. I should take that out. Yeah, sorry, that's confusing. Okay. So bladder, this is where we see transition epithelium. These are called umbrella cells, or like here's another one right here. This is kind of characteristic of transition epithelium where it can like kind of compress and expand as needed. Here's a ureter, also transitional epithelium. So kind of as a rule of thumb, like pretty much everything in the GU system will have some sort of transitional epithelium because it needs to accommodate for urine passing through it. Here's the vas deferens. You have some pseudostratified columnar epithelium with stereocilia in order to propel the maturing sperm through the GU system. And here are the seminiferous tubules, also pretty distinct. So the spermatogonia will kind of move towards the center of the lumen as they mature. And then you have Sertoli cells usually within the kind of tubule, and then you have Leydig cells outside. Right. And then epididymis, also ciliated, you'll see like a lot of maturing sperm inside. Right. And then a prostate here. Also secretory, so you'll see a lot of cuboidal epithelium, some columnar. And then breast is what you're looking for are these mammary glands surrounded by like fat and kind of a lot of connective tissue. And the ducts, you'll see like cuboidal epithelium, which makes sense because they're secreting things. And finally, ovary. This is a zoomed in picture of like a maturing like egg, but ovary, it was like kind of a zoomed out view, I think on the next slide. You can see like a maturing like corpus luteum here. You can see some like growing follicles. And finally, fallopian tubes, you'll see like this simple ciliated columnar epithelium, also non-ciliated, and kind of at a macro level, it looks like this. So I know that was kind of very fast. I think most of this is just like just looking at the picture. So I think me talking isn't going to be that helpful for helping you learn. But these are some general like websites that are good for practicing. So I think the MedPix at like UCSC is really good. You can like make quizzes and just like test yourself on like identifying different images. Some of the Yale images are good as well. And I know when I used to write the practicals and theory and stuff, like I would always throw in a few histology questions. So I think it is worth your time to at least look over some of these. But yeah, I know that was really fast. Any questions about any of that? Or do you want me to go back for anything? Okay, cool. Just keep things moving. I'll have you guys take a break in a bit, but we can get started on the animal phys section just for the sake of time. Okay, so for this animal phys, I won't go as fast. I think these concepts are pretty important to know. How I kind of structure this is I think just like within this 2-hour lecture, it's like it'd be impossible to teach everything. So a lot of these I just picked out some like what I think are high yield concepts or like concepts that are like a little bit more difficult to understand. And just going through. So this probably will seem kind of scattered, just like random concepts from different systems. But I think this will be like a good like high yield review for your exams as well as for those of you going to IBO. So let's start with imaging again. So I think just generally when you're talking about imaging, if you're communicating like scientifically or medically, it's good to just be oriented. So starting with top to bottom, superior, be closer to the head. Sometimes you'll hear it as cephalic. Inferior, near the floor, near the feet. Sometimes this is referred to as caudal or caudad. Lateral, medial. This is referring to the midline of the body. So whatever's closer to the midline is more medial, and farther away from the midline is more lateral. Proximal versus distal, this is in relation to the origin. So if you're talking about the arm, distal is the farthest point from the origin, which is kind of the shoulder girdle here, and proximal is closer. And then you have anterior, posterior, also referred to as ventral dorsal. So just be comfortable with these terms. Okay, and then we have different planes. So we live in a three-dimensional world, so there are 3 different planes that we care about. First thing is the frontal or the coronal plane. So this is the green box here, where you kind of slice you're slicing the image kind of like from the front like this. And then you have a sagittal plane where you're, going 90 degrees and slicing it this way. And then you have a transverse plane or an axial plane where you're kind of making a horizontal slice. So also just be kind of aware of these 3 different planes. Okay, so let's move on to some different ways of imaging. So this is X-ray, and this is good for visualizing like bones. This is also good a lot of times if you need like a quick scan in like the emergency room, like X-ray is the first thing you're gonna do. And I don't think you'll really be responsible for like fully interpreting an X-ray, but I think just I think it's fair game to like be able to identify like a pneumothorax, like a PE or something like that. So this X-ray here is showing some sort of pathologies. Does anyone want to guess what it is? If you said pneumonia, that would be correct, specifically in the right middle lobe, and you see there's like a little abscess or something here. And I think big things to look for the X-ray for like if you're getting a patient with a pneumothorax, you'll see, I might have some pictures later on, but you'll see that sometimes you can like literally see the lung kind of collapse on itself like over here. What you want to look for is like the edge of the lung. And if it's like not fully expanded, that can tell you that's a pneumothorax. Sometimes you'll see like, so this is the trachea here. If you see the trachea like deviating like towards the left or the right, it could also be because like a tension pneumothorax is pushing the trachea one way or another. Those are some things to look for. Also for pleural effusions, like what you're looking for, you'll see like a lot of fluid probably collected like down here. And those are usually pretty obvious to see. Okay. So next we have CT. This is using, CT is basically just like 3D X-ray. You just like take a bunch of X-ray slices and then make it into a 3D image. So the image on the left here, what plane are we looking at?
Be louder.
Yeah, someone shout it out. Okay. If you said frontal or coronal, that would be correct. And then how about this image on the right? So could you repeat that?
Transverse.
Yeah, transverse or axial. Very good. And does anyone know what the image on the right is showing? You have some nice arrows pointing to it. Okay, these are just extra credit. I don't think we'll give this to you on like an exam, but this is a aortic dissection. You can see ascending aorta here is like a pretty big dissection in the wall. Here's descending aorta. So this is like a pretty, here's the pulmonary artery here. It's a pretty big dissection. And on the left here, so also for CTs, like to orient yourself, the images are flipped. So the right side will be actually on the left side of the image. And how I think of it is like, imagine the patient or the person kind of like standing in front of you face to face. So then their right becomes your left and your left becomes their right. And same for this one, for an axial view, you're kind of like looking at their feet up towards their head. So the patient's like laying down, like face up on the table. So this is patient right, and then this is patient left. And then image on the left here, what is this organ right here?
Liver.
Yeah, this is the liver. How about this? And this is not normal. There's like some sort of mass on here. So this is the spleen. This will be on the left upper abdomen area. And then you'll see bowel here. It's like abdominal aorta. Yeah. Okay, so MRI. This is using, I think, like the physics of it is like you like excite the hydrogen atoms and then they like align in a certain way and you get these images. This is good for soft tissue. If you're doing a scan of the brain, you usually use MRI. And if you're like trying to visualize soft tissues like tendons, ligaments, MRI is also the way to go. So image on the left here, this is showing multiple sclerosis. You see these white matter lesions kind of scattered throughout the brain. And then image on the right here is showing, does anyone know what this is showing?
Okay. Tendon.
Yeah, so this is an Achilles tendon here, Achilles tendon tear. right here. And then finally, you have ultrasound. This is good. This is also really fast. You can do this at the bedside. And this is used for a lot of like abdominal. So if you have like some sort of GI pathology, also use a lot in like gynecology, obstetrics, where you can do it transvaginally or abdominally. So on the left here, someone told me what we're looking at. Yeah, so this is a baby here. This is what it looks like. Here's the head, here's the body. And on the right here, so this is not a baby. What is this?
Eric.
Someone said air. Okay, so this is the gallbladder, and you can see a stone. So this is showing like gallbladder inflammation, which is like a lot of like liver, gallbladder diseases. Like first thing you do is ultrasound because it's fast and you can see the structures pretty well. Okay, so that is it for imaging. Let's move on to cardiology. Okay, so hopefully you know what this is, and hopefully you know that there are 4 chambers of the heart. So I'm not going to go through this. But generally, I think it's good to just review the cardiac cycle. So we know that there's atrial systole and ventricular systole. And main thing to note is that for ventricular filling, like most of it, I think like 80% happens passively through gravity, where the blood, so let's start here. So the blood, well, most of it will passively flow from the atria to the ventricles, just like from the, power of gravity. And then at the end of this part, the atria will contract and kind of squeeze the remaining 20% of the blood into the ventricles. So that's the atrial systole phase. And this is matches up with the P wave on EKG. And then next phase is the ventricular contraction. So there is a volumetric contraction, which means that the volume stays the same. So the ventricles are compressing, pressure in the ventricles are increasing, but the blood isn't like being released into the body, so the volume is staying the same. But once the pressure of the ventricles exceeds the back pressure, the afterload of the pulmonic or aortic valve, the blood will then shoot out into the body, and that would be the ventricular systole, and this is the represented by the QRS on EKG. And then you have a T wave, which correlates to ventricular repolarization, and then the cycle kind of continues. So hopefully this is a review. Same for this. This is just kind of a graph of the cardiac cycle. Just same thing as before. You can follow. This like shows that I think that focusing on the top here, this is like a pressure tracing for different parts of the heart. So the aortic pressure will remain fairly high. And then you'll see like a left atrium pressure and left ventricle pressure. So the main thing that we're looking at here is when the left atrial pressure like intersects with the ventricular pressure, that's when atrial systole stops, and then you have your isovolumetric contraction going on here. And once the pressure within your ventricles exceeds the aortic valve pressure, that's when the blood is actually able to leave. So this is the ejection phase here. And then once enough blood leaves, the pressures will kind of, the pressure in the ventricles will be less than the aortic valve, so that's when the aortic valve closes. And then you'll see the heart relax. And then once the left atrial pressure then exceeds the ventricular pressure, then the mitral and tricluster valves will open and allow blood to start to fill again. So, and then you have heart sounds as well. So S1, these are like the lub dub corresponding to the closure of the valves. And you can also have some extra heart sounds called S4 and S3. So does anyone know what S4 can represent? I don't know if you went over this. So S4 heart sound, this will you'll hear it before the S1, and this can be indicative of like hypertrophy of the heart. So if you have like hypertrophic cardiomyopathy, if you have like a really enlarged like left ventricle from like hypertension, sometimes they hear an S4. And then S3 will happen after the S2 heart sound, and this is usually a result of fluid overload. So if you have like a dilated cardiomyopathy, if you're like really fluid overloaded, you might hear an S3. This is also normal in a lot of like younger people, like athletes, pregnant people. So sometimes an S3 can be normal. Okay. And this is kind of a representation of the heart as a circuit. And you'll have like a series of like resistors, batteries, and this is kind of a more simplified view if you're not really physics savvy like me. But I think generally like it's like pretty good to just like kind of know. I think the main thing is in terms of resistance, I think this is like kind of correlated to Ohm's law. So Ohm's law we know is current is equal to the voltage difference over the resistance. And this is paralleled in the cardiovascular system where we see that the current can be equated to Q, or blood flow, is equal to the pressure difference over resistance. So someone told me something that can increase the Q, or your cardiac output. And I don't know if someone in the front can just like relay the answers over so I can hear them.
That's awesome.
Yeah.
Okay, so Q or cardiac output, something that can increase this is like thyroid hormone, catecholamines, like sympathetic, like stimulation. And then some things that can decrease are things like heart failure, shock, arrhythmia, where the heart isn't able to pump as well. And then in terms of the P, or the pressure difference, what is something that might increase the pressure difference or decrease it?
So somebody said a higher contractility.
Okay. Yeah, so contractility I think that's more related to cardiac output, but can definitely increase your pulse pressure as well. Whether if you're using like an inotrope or something, if something's like something that's increasing contractility, that'll can widen your pulse pressure. Narrowing pulse pressure is usually related to like heart failure, if your heart isn't able to pump as well. If you have aortic stenosis, that can also reduce your pressure. And the next thing, I think resistance is something that's important to talk about. So this is on the bottom left here, it's called like Poiseuille's law, where this is like the relation between flow rate and like things like pressure, radius. So I think the main takeaway from this is that radius is, or flow rate is related to radius to the fourth power. And essentially what that means is like changes in radius will affect your flow rate a ton. And this is how the heart will modulate flow through vasoconstriction or vasodilation. So for example, if you vasoconstrict and increase like right here, if you constrict the blood vessels a lot, the flow rate will go down like very exponentially. And same for vice versa. If you increase the radius, the flow rate will increase a lot. And this is how the heart does a lot of its work, and how a lot of like diseases will manifest. So I'm sure you're familiar with the formula for cardiac output of heart rate times stroke volume. And the stroke volume can be affected by a lot of things. One of them is like contractility, which someone mentioned, preload. So the Frank-Starling law, which is like how the degree of like stretch of your muscles will be related like how much it can compress, like that. So preload will affect your stroke volume as well as afterload. So hopefully everyone is familiar with like preload and afterload, but that's essentially just like preload is like how much fluid is like going into the heart, and afterload is like how much fluid is like trying to move back into the heart. So if you want to pump blood out of the heart, you need to be able to exceed the afterload pressure. And some things that will increase afterload, one big thing is hypertension. So if your blood pressure is really high and your aorta has a lot of like, if the pressure is like increasing your aorta, then your heart has to work harder to pump blood out. And this will present as like left ventricular hypertrophy because the heart needs to thicken in order to generate enough like force to push the blood out. And then this is a pressure volume loop or pressure volume diagram. So this is, I think, pretty important to understand because like this can be used to represent like a lot of different like heart diseases. So being able to like recognize and interpret this, I think, is important. So in terms of like just following it along, we'll start with the bottom left here, A, where this is when the mitral valve opens and then your left ventricle starts to fill with blood. So if you're going from left to right, from A to B to C, the left ventricular volume is increasing as the blood is flowing from the atria to the ventricles. And then here at the end of atrial systole, your mitral valve will close. And this is when the isovolumetric contraction occurs from C to D. So you know it's isovolumetric because the volume isn't changing, but the pressure is going up. So this is when the left ventricle or the ventricles are kind of squeezing, increasing pressure. And at point D, this is when the pressure exceeds the aortic pressure. So then the aortic valve opens and then the blood can eject. So from D to E to F is when the kind of ejection of blood occurs. And then aortic valve closes at F, and then there's relaxation back to the kind of starting point at A. So that is the entire thing. And some things to know are the stroke volume is the width of the graph, and which makes sense because you know stroke volume is how much blood is being ejected from the blood after each like heartbeat. So the difference between A and C is like how much blood is leaving the heart. So that's the stroke volume. C is the end diastolic volume, so how much blood is in your heart at diastole, and then A is the end systolic volume. So this picture is terrible, but the red is an abnormal pressure volume loop compared to the normal one. So someone tell me what disease this is showing. Okay, great. Aortic stenosis, and this is, you know this because there's increased end systolic volume, as well as like increased afterload, and this will present as like a very increased pressure. And anyone know what the murmur would sound like for this?
Somebody said between S1 and S2 during ventricular contraction.
Great, yeah. So between S1 and S2, so it's a systolic murmur. And they call it crescendo decrescendo because it kind of will go up and down. And then usually the S2 sound will be more faint. But yeah, that's good. Good that you know that. Okay. Next, we'll talk about the cardiac function curve. So this is kind of the set point or where the heart operates. And this is the balance between like systemic flow and the central venous pressure. So there are things that can shift the cardiac function curve as well as shift the vascular function curve. And these are some good things to know. So for example, there's kind of a lot going on in this graph, but for cardiac output, increasing cardiac output through an inotrope, this will shift the graph up. So then if you keep, let's say the blue line of the vascular function curve is the same and you give an inotrope, then it'll shift left to here. So this is where the heart will operate now. So there'll be a new cardiac output and like a new end diastolic volume. So inotropes will shift the cardiac function curve, and the blood volume curve is usually shifted by fluids. So if you move it to the right, you're like giving, IV fluids. If it's moving to the left, maybe the patient lost a lot of blood, hypovolemia, or things like that. And then the entire, both curves will shift if you're changing the total peripheral resistance. So if it's going up and down, the entire graph will shift. And so now let's go into some EKG stuff. I think it's good skill to know how to read an EKG. So this will be hopefully a review for you, but the P wave, the kind of the entire QRS complex, you should know that the P wave corresponds to atrial depolarization. The QRS is the ventricular depolarization, and then you have a T wave. for ventricular repolarization. Sometimes you'll see a U wave after the T wave. Does anyone know what that indicates? Yeah, so I wouldn't expect to know this, but hypokalemia will present with a U wave after the T. You'll see like a little bump there. I think that's the main thing. And for the different leads, I wouldn't worry about memorizing this too much, but this is usually good for like localizing. For example, if you have a patient that's coming with a heart attack and you see some changes in, for example, leads 2, 3, and AVF, that can tell you like what part of the heart is being affected by the heart attack or the infarction, and sometimes you'll be able to figure out like which artery is being affected. So you have these V leads. So usually if you like get a 12-lead EKG, it'll come with 6 V leads, starting kind of medially, going laterally, V1 to V6. And you have leads 1, 2, and 3. So 1 will be kind of going laterally to patient left. You have 2 leads that go inferiorly, 2 and 3. And you have AVL for left, AVR for right, and AVF for going down. And I think main thing to know is in terms of the electrical signals, if it's positive or negative, if the electrical signal in the heart is traveling kind of the same direction as the lead, on the EKG, it'll be positive. And then if it's going the opposite direction, it'll be negative. So for example, let's go back to this. Okay, so let's say we're looking at the P wave. So you know it's starting in the right atrium where the SA node is, and it's kind of traveling down the heart. So the P wave, what direction will it look in lead 2? Up or down? A positive or negative? Yeah, so I heard positive. That's right, because you know that in a normal heart, or I don't think there's any heart where the P wave will be going like up and to the right, but you know it's starting the right atrium and kind of going downward. So in lead 2, the P wave usually you'll see it positive. And then you should know that in AVR, the P wave will always be negative because it's going opposite from AVR. So kind of a general schematic for when you're reading an EKG. Then some things to look at are, I think for the purposes of kind of your exam, the main things to know are just like rate, rhythm, and yeah, I think it's just mainly rate and rhythm. So for rate, how you calculate it is, so each of these like small boxes, oh, okay, let's see if we can get a better picture. Okay, so this is a big box, and then there's 5 smaller boxes inside. So each of these smaller boxes is 40 milliseconds. So a really quick way to figure out the rate is you count the number of big boxes between the 2 QRS peaks. So for this one, there's like 1, 2, 3, and then about 4. And then to figure out the rate, you do 300 divided by the number of big boxes, so 300 divided by 4. So so the rate for this is like roughly 75 beats per minute. So that's how you calculate rate. For rhythm, what you're looking for is if there are P waves present. So main thing is if you see a P wave here, so you want to see if there's a P wave before every QRS complex, and that'll tell you if it's a sinus rhythm. So if the rhythm is originating from the SA node, or sometimes you'll have rhythms that are not originating in the SA node, for example, AFib or atrial flutter. And that'll be important because you won't see P waves because the rhythm is not being generated by the SA node. And that can be important for you to know as well. And then also just like, you should take a look at if the rhythm is regular or not. So this one, you see the QRS complexes are pretty evenly spaced out. So this will be a regular rhythm. So this one, like in order to interpret, I would say rate is about 75. Rhythm is regular, and it's like a sinus rhythm because you have P waves before each QRS. Okay, so here's another EKG for you. So anyone want to take a try at interpreting this, or you can interpret this on your own and then we can review? Yeah, AFib, but what is the rate?
It's not constant.
Okay, yeah, that's right. It's not constant. So what you would do in this case, so usually if you have the whole strip, like, so like on the bottom here, usually lead 2, you have a full strip. And this, I believe, is like, I think like 10 seconds. So what you can do is you can count the number of QRSs that are in the rhythm strip and multiply that by 6. So for this one would be 1, 2, 3, 4, 5. So there's 10 QRS complexes here, multiplied by 6, so roughly rate is 60. So for like an AFib, this one, assuming this is a 10-second strip, there's 9, so rhythm's roughly like what, 54. And then yeah, so you guys should know it's not sinus rhythm and the rate is irregular, or more specifically it's irregularly irregular. Okay. And how about this one?
This is,
I don't think so, but they're not just, oh, yeah.
they are completely.
No, this might be type, Mobit's type. I think it's type 1. Wait,
Wait, no, it's not type 1. Type 1 is just delayed. This is just type 3. This is definitely.
Oh,
Yeah.
But there's, oh, yeah,
It's a
okay,
better
type
than type.
3AB block.
Yes, that's very good. So this is a type 3 AV block. You know that because there's a dissociation of the P waves and the QRS. So you see that the P waves, these are the P waves, they're still very regular, but the heart is basically just ignoring them and generating its own rhythm, and which is evidenced by this. So this is a 3rd degree AV block, and it's originating like below the level of the AV node. There's some disruption of, the conducting system. It could be because of like a heart attack or something else. And someone tell me what the rate is that we're looking at here.
Isn't it 1.40? Like 42. Isn't it?
Yeah, I heard someone say 42, so that's 42, 43. So you'll see there's 7 big boxes between each QRS peak. So 300 divided by 7, roughly 42, 43. So your rate is around that. And for this case, you probably need to give the patient a pacemaker because BPM of 40 is not going to be sustainable for the bodily functions. And so now let's talk a little bit about ST elevations or ST depression. So this is something that you're looking for in a heart attack. So sometimes you'll see like ST elevation or ST depressions. So STEMI versus NSTEMI. So STEMI is like a ST elevation myocardial infarction. And if you see a ST elevation, that is suggests that it's like a pretty bad heart attack. And because you'll only get ST elevations when the entire thickness of the heart wall is being affected by the infarction. Versus an NSTEMI or non-ST elevation myocardial infarction, like maybe 50% of the heart wall is being infarcted. So then the signal or the electrical signal can still kind of go around it. So it'll present as a depression. ST depression. And sometimes we get T-wave inversions as well, which is usually you'll see that in an NSTEMI. So these are some things that you'll look for. Okay, and then let's talk a little bit about the vasculature of the heart. I wouldn't worry too much about like memorizing this for your exam, but this is used for like localizing heart attacks. So the 3 main arteries that are on the heart. So the first one is the LAD, or the left anterior descending. And you get the left circumflex, which is kind of going around the heart, and then we have the right coronary artery. So in terms of leads that these correspond to, if you see infarctions or let's say you see ST elevations in like V1, V2, V3, which if we go back, we know that V1, V2, V3, this is kind of anterior of the heart. So this is where the LAD is running. So this clip art actually has like pretty good arteries on it. So this is the LAD. So V1, V2, V3 elevations, you'll see that in the LAD. If you see a circumflex artery infarction, you'll usually see elevations in lead 1 and lead AVL. And if you get a right coronary artery infarction, those will be inferior leads, so you'll see 2, 3, and AVF. And another thing to be aware of is that the right coronary, so if we look at look at where the right coronary artery is running. So what important structure in the heart is this supplying? That might cause problems if you get a patient with a blockage in the right coronary artery. Okay, so what part of the heart is this right here? Which chamber? This, yeah, you're right. This is the right ventricle, this is the right atrium. Important part of this is the right coronary artery supplies the SA node over here, as well as fibers of your mitral valve. So if you have a patient that comes in with a infarct of the right coronary, you can have problems with, you can have like, for example, a 3rd-degree heart block, or not 3rd-degree, but you have some sort of like heart block arrhythmias because of the SA node getting messed up. You can also have like mitral regurg if the like mitral valve like muscles like get damaged. So those are, I think, the main things. So that was cardio. Any questions about that? All right, cool. Let's get started. I know you guys have your practical tomorrow, so we'll end early so you guys have some time to study and sleep. And I think just like generally for the practical, from what I remember, I think there's like not much more you can study tonight. So I would just focus on getting a good night's sleep. And I feel like the biggest thing that people get stuck on is like timing. Because like when we write these practicals, we don't really consider like, oh, how long will this actually take to finish? So some of it might actually like not be quite possible to finish completely. So usually what I would do is like when you first get the practical, like flip through it, see if there are any like easy points that you can get first. Because like what you don't want to do is like run out of time and like leave a bunch of points on the table. So like don't feel the need to go in order if you don't have to. Like if you get like a tray of like 5 different invertebrates and they're like, you need to dissect all of this, like I would do the one that you're most comfortable with first. Just make sure you're like grabbing those easy points. I don't know what your practical setup is, but like it'll probably be a mix of like some dissections. For biochem, you might have to do some experiment stuff. I remember when I was at IBO, like we had to like make like a battery and like calculate some stuff. Like don't study batteries tonight, but like you might have some, you know, interesting stuff. But overall, like it'll definitely be hard, but I think it's like pretty fun experience. So yeah. Okay, so we'll try to get through the rest of this fast. I just have a couple more systems to go through and some practice questions, and then I'll let you guys go. But let's go on to pulmonology. So okay, hopefully you know what the lung looks like. So in terms of like lung pressures, like the lungs are kind of constantly like a negative pressure. So that's why you get like pneumothoraxes or lung collapses if like you puncture the chest wall because the lungs are constantly trying to compress. And there's like just be familiar with like the different pressures where a lot of your inspiration is driven by decreasing intrapleural pressure. So when your diaphragm contracts, brings the lung downwards. So decrease your intrapleural pressure and draw air into your lungs from the environment. And I think the main thing, and just like in terms of the spirometry results, just be familiar with like the different lung volumes. I think main thing is tidal volume is like the amount of air that you're inspiring or expiring and like a normal resting breath. And then you have like an inspiratory reserve volume, which is like the most amount of air you can inspire. You have an expiratory reserve volume, which is like the most amount of air that you can like release. And then everyone has some degree of residual volume, which is like quote unquote dead space. Some of it is because things like the bronchi and the trachea, they don't participate in gas exchange. So it's like inherently considered like dead space. Other times like disease processes like emphysema or things like that can increase the amount of dead space that you have. So I think this is something that you should be generally familiar with. And then also these flow volume loops. So this kind of similar to the pressure volume loops that we did in cardio just now. This is something that I think is good to just be kind of aware of. So you'll have the bottom is the expiration and the top is the inspiration. And the reason that the inspiration flow, it's a kind of a straighter slope is because of the surfactant where the inspiration can take place faster than the expiration. And this is like the peak inspiratory flow rate is like the top and the peak expiratory flow rate is at the bottom. So I think high yield stuff for this is in terms of lung volumes, like you're gonna have obstructive and restrictive diseases. And for reading this graph, this gets a little bit confusing because for whatever reason, they put the higher volumes on the x-axis on the left. So if you're shifting, so the dotted line is the normal. If you're shifting your flow volume loop to the left, that means you're operating at a higher long volume. And if you're shifting it to the right, you're operating at a lower long volume. So really quick, someone tell me one reason why the flow volume loop might shift to the left.
Might have like a bunch of like air in the lungs.
Yeah, sorry, I didn't quite catch that, but like it's probably some sort of obstructive lung etiology. For example, COPD would be a very classic example of this. Acute asthma can also present as an obstructive lung disorder. And then on the flip side, restrictive, this is, you think of this as like the lung kind of being like shrunken down. It's operating at a lower volume. So this is a lot of like pulmonary fibrosis, where the lungs are becoming like less elastic and like more kind of like shriveled up. It'll operate at a lower volume. And then a quick note on ECMO. So this is used for patients with heart failure or heart and lung failure. Usually as kind of like a last ditch effort. No one's going to be on ECMO for a long period of times. Usually, for example, during COVID, when there weren't enough ventilators, like patients will be put on ECMO just until like a ventilator can open up. Also, patients with like really late stage heart failure where they're waiting for a transplant, and they can't sustain their own circulation, they can be put in an ECMO machine, kind of as a bridge to transplant. And the main difference is there's something called VA ECMO, which is veno-arterial, and there's VV ECMO or veno-venous. So the main distinctions are VA ECMO, where you have, so the ECMO machine, there's like an oxygenator and then a pump. And the idea is that this will oxygenate your blood for you outside your body because your body isn't able to do it itself. So for VA ECMO, you'll have one part of the machine attached to like a femoral artery and one part in the vein, which is why it's called the veno-arterial. And this will be attached in parallel to your circulatory system, and this will be able to support both your lung and your heart. So this is for patients who need both heart and lung support. You'll put them on VA ECMO. And then VV ECMO, you'll put it in two different veins. This one is in like the femoral and the jugular. It can also be in both in the femoral vein. And this is attached in series to the right side of your heart circulation. This only takes over your lungs. So in this case, the heart should still be working, but maybe the patient had like really bad pneumonia, their lungs don't work anymore. So you have an ECMO machine basically oxygenating the blood for the patient if their lungs don't work. So here's another picture of that. So let's move on to the renal system. And I'm sure you guys are all pretty familiar with like how the nephrons work and everything. So I won't go too much in depth with that. I think something just like be familiar with where the different diuretics are acting. So just very generally, like loop diuretics, like the name suggests, is working in the loop of Henle. And what it does is it's going to like inhibit like the sodium, the NaCl transporters. And so the body will be reabsorbing less NaCl and more of it's going to be excreted out in urine and with it water. So you're losing water by preventing NaCl excretion. You can also have thiazide diuretics, which will work in the distal tubule. Also very similar, it'll promote secretion of sodium and water will come with it. And also something to remember is that for both loop and thiazide diuretics, this can present with hypokalemia because you're losing more potassium ions as well. So yeah. And also hemodialysis. So this is usually for patients with maybe they like, if they have kidney failure, maybe they ingested some like toxins that you need to like get out of the body. If they have like bad acid-base disorders like acidosis, where you need to like manually go in and filter out the blood, you do hemodialysis. So this can sometimes they do it. There's like peritoneal dialysis where they like put the machine into the abdominal cavity and then like they can filter the blood that way. Sometimes it's just through the blood. I'm not going to go into too much of this, but there's like a kind of like a selectively permeable membrane where they run the blood through and it'll filter out the toxins. And okay, so let's go into neurology. So this is the spinal cord, cross-section of the spinal cord. And some things to know is there are two different parts. So know there's a dorsal root and a ventral root. So the dorsal root will contain more like sensory nerves, ventral root will be more motor nerves. And the dorsal roots, these will be like afferent fibers. So they'll be sensing maybe there's like a nerve ending in your foot. It'll send something, send it up the spinal cord. It'll synapse with the dorsal root ganglion, and then it'll go into the dorsal root and dorsal horn. And then the ventral horn is an efferent fiber, so it'll send out fibers, motor fibers to like your muscles. And then, yeah. Okay, and then this is a diagram of some different pathways. So there's kind of a lot going on here. I think the most important ones are you have your dorsal column pathways or dorsal column pathways here. So these ones are responsible for like biggest thing is balance. Also things like fine touch, proprioception, vibration will be sensed by your dorsal columns. And then there are the spinothalamic tracts here. And these are responsible for pain and temperature sensation. And then the last one I'll talk about are the corticospinal tracts. So the ones in red here. And these are your primary motor pathways. So your somatic or like motor system, your conscious control will be running in these corticospinal tracts. So kind of following the pathways down. So these are corticospinal paths. For example, let's say this is controlling like your bicep muscle. So there will be a motor neuron or your motor cortex that runs all the way down, and it'll cross over or decussate in the medulla. So I think for these pathways, like the biggest thing is just remember where it's crossing over. So all or most motor pathways will cross over in the medulla. So like the right side of your brain will be controlling the left side of your body. After it crosses over, it'll synapse with a motor neuron in the ventral horn, and this motor neuron will then travel to whatever effector muscle it's going to. So this is a two neuron pathway. So most of your motor pathways will be 2 neuron pathways. And they have the ascending column. So these will be all 3 neuron pathways. So on the left here, this is the dorsal column. So for example, so again, this is sensing things like vibration, light touch, balance. So for example, let's say you have a sensory nerve ending in your foot, and you like tap it lightly with like a cotton swab or something. So that will be sensed by that nerve ending. It'll travel up into your spinal cord, and it'll synapse in the dorsal column because this is the dorsal pathway, and it'll synapse in the medulla. And similar to the motor pathway, this also crosses over in the medulla. And then it will go into your thalamus, and the thalamus is kind of the like relay point for pretty much all of your sensory pathways. And then there's a third neuron that will go from your thalamus to your somatosensory cortex where it'll be processed. So that's for the dorsal column. And then the last one I'll talk about is the spinothalamic column. Oops. And this again is for pain and temperature. So same thing, let's say the same part of your foot, instead of tapping with a cotton swab, you poke it with a needle. So the pain will be sensed. And the main difference here is that the spinothalamic tract, this crosses over in the spinal cord itself, like around the level of where it's sensed. So this is not crossing over in the medulla. So the motor or the sensory neuron will sense the pain. It'll travel to the spinothalamic tract. It'll cross over in the spinal cord and then go up into the brain, into the thalamus. And that's the main distinction. So instead of crossing over in the medulla, it's crossing over in the spinal cord itself. Okay. And why is this significant? So this is useful for localizing spinal lesions. And this is because let's say you have a patient, let's say patient comes in after like a car accident, and then they're complaining of like right-sided paralysis, left-sided loss of pain and temperature. So what is going on here? So this is something called Brown-Séquard syndrome, which is a hemisection of the spinal cord. So in this case, like the entire right side of the spinal cord is being affected. So how would this present? Oops. So let's say the entire right side of your spinal cord doesn't work. So you'll have loss of motor function on the right side because the motor fibers that are trying to get down on the right side are not able to get to the muscle. So you'll have paralysis. And then same for like vibration sense and like balance, fine touch. This is in the dorsal column here. And these neurons are also being disrupted. So on the right side, you'll have loss of like vibration sense, proprioception. But then the loss of pain and temperature sensation will be actually on the opposite side, on the left side. And that's because you have fibers in the left side. So the fibers on the left side are trying to cross over to the right at the level of the spinal cord. And since the right side of the spinal cord is being disrupted, it's actually going to affect the left side of the body in terms of pain and temperature sensation. And that's because the neurons are crossing over in the spinal cord itself and not the medulla. Okay, and any questions about any of that so far? Okay, awesome. Next equation, I'm not gonna go into too much of this. And endocrine system, just one quick note on this. I think most of you should have a good handle on this, but the main thing is that just like, I feel like once you understand one endocrine pathway, you pretty much understand all of them. So the endocrine system is like mainly made up of these like axes. So this is the hypothalamus, pituitary, gonadal axis, or HPG axis. And all these pathways are driven by feedback pathways, where generally the most end-stream hormone, in this case, testosterone or estrogen, will kind of perform negative feedback on upstream, so the pituitary and the hypothalamus, and that's how the body kind of regulates this. So I think just like be able to be comfortable like thinking about these pathways, like what happens if, you know, there's a drug that inhibits the anterior pituitary, or let's say there's a disease that, you know, interferes with estrogen production, like what would happen to the upstream and downstream hormones. And same for this is like the ACTH stress pathway, same thing. And then finally, a note on immunology. So immunology, the cells have two general lineages. There's the myeloid line and the lymphoid line. So lymphoid line, like the name suggests, will differentiate into lymphocytes, B and T cells, as well as NK cells. And then whereas the myeloid stem cells will differentiate in everything else. So you have like your like neutrophils, eosinophils, monocytes, basophils, as well as platelets will come from the myeloid stem cells as well. And then final slide, just in terms of the immune system, I think just be familiar with how B and T cells are being activated. So for example, for helper T cells, it'll be an antigen presenting cell, presents its antigen on MHC type 2. So the T cell receptor will recognize the antigen, as well as there has to be a co-stimulatory signal with the B7 CD28, and that'll activate the helper T cell. And then that helper T cell can then go and activate B cells with a similar process where B cell presents an antigen on MHC type 2. Helper T cell will see that, as well as bind with a co-stimulatory ligand, in this case the CD40, and that'll activate the B cell to go off and, you know, do its functions. So any questions about any of that I went over? I know that was really fast and kind of like probably didn't make sense, but again, I think it's hard to cover all of anatomy and phys in one session. So it's just touched on some main concepts. Okay, so in the last about 30 minutes, let's see. I do have some practice questions. Hold on, don't look at that answer. Okay, so I made like a quick little Jeopardy thing. I know guys you have your practical tomorrow, so if we want to end right now, you guys want to go study, I'm fine with that. I can just send this out. You can like look at it on your own time. If you wanted to do some questions right now, also fine with me. It's up to you.
She was saying they'll do a few questions.
Okay, cool. So why don't we split into like 2 teams? Maybe we can do like 10, 15 questions and then you guys can be dismissed for the night.
Front row versus the rest. Front row versus the rest.
Front row versus the rest. Okay. Okay, I will need someone from the back, just like a representative, to answer the questions because I can't hear it on my end. But cool, yeah. Okay. So let's see, front row. What question do you want to see?
Oh, God. Oh, what is shit? We lost. We lost. Yes. Wait, we have sidewalks. We have sidewalks.
Wait, I'm like-
Wait,
Keon is here. Can you use sidewalk style?
Yeah.
Wait, I'm not seeing your horse at cycle.
Yeah.
Are you gonna do sidewall style?
Yeah.
Oh, no,
Okay.
no.
Whoever raises your hand.
Wait, I also did not wear my contacts, so I don't think that's. Oh, my.
I mean, yeah, we can do sidewall style if you want to do free for all. I mean,
Let's go
Wait, yeah,
Jeopardy
let's do
style.
sidewalk. Wait, let's do
Jeopardy style. It's No. too, no, too
Alright.
tired.
Yeah, it's just. Go for it.
Jeopardy style.
everybody, all right. We can do front row versus everyone else then. Okay, let's start with front row. What do you want to see?
Oh, cardio 500.
Cardio 500. You're starting card. Okay.
Wait, this is bundle branch. Wait, no, not
Wait,
bundle.
this is this is STEMI at the
Semi's in B2.
There's no
B3,
bundle branch, there's no-
B4, so it's in the.
Is it junction?
it's like
And
left
there's ST
ventricle.
depression.
It's AB. It should be junction.
It should be junction. Wait, this is not bundle branch. It's a bundle branch, there's a junction.
Not left.
I think it's left ventricle.
I think it's left.
Wait, you're right, I'm dumb.
Left ventricle.
It's left ventricle. How do we answer that?
You don't have to do Jeopardy style, but more specific, I'm looking for which artery is being infarcted.
It's so good. No quotes for you.
This is gonna be on a Friday tomorrow.
I don't know.
Wait, which arm is final?
We don't make it.
Okay, someone give me I need a final answer in 10
We
seconds.
don't have to answer.
We don't make it.
It's aorta.
What is wrong with it?
Aorta.
Single with
You say aorta?
We don't know.
We don't know.
I don't know. Okay.
Aorta is our final answer.
Aorta? Okay, well, whoever said Widowmaker should have. Yeah, so this is the LAD, which is also known as the Widowmaker because so many heart attacks happen here. Um,
I didn't even know this is an artery.
yeah, so this is you see ST elevations in V2, V3, which are like anteroapical leads. So this should tell you it is a LAD infarct.
Yeah, no.
All right, back row, what do you want to see?
Wait, let's do roll 500.
I swear to God,
They said Euro 500.
Neuro 500? Okay.
Yeah, wait, so the right has motor deficiency and the left has sensory.
Right motor, left sensory. Okay, so this one, it'll present with there'll probably be bilateral motor, some bilateral motor, but the main thing is since it's, so this is called central cord syndrome. And the main thing that's being disrupted is the spinal thalamic tract, since it's the one that's crossing over kind of in the middle here in the spinal cord. So you get bilateral loss of pain and temperature sensation.
Project your voice a little. Okay, wait, wouldn't it like split the sides instead of splitting it like by like horizontally? Wait, oh yeah, that's the, okay, wait, that's the wrong.
They can see.
Was there a question about that?
No.
No, they can see it.
No,
Okay.
we're just dumb.
Okay, yeah, no worries. Okay.
I think 100 is. Fine.
It's still 300.
It's still 300? You guys
We're
back?
not
You guys,
going bigger.
With the 500.
you guys back down from the 500s? All right.
Hey, yo, we should-
Oh, no. Bro. Wait, surely that is like the pancreas, right?
No.
What?
That's the brain.
Wait, those are the kidneys.
Wait, is that?
This is not.
That's the brain.
Wait, brain or MRI? This is a brain MRI. Someone
Wait,
fucked
this
up.
wait, this is not even a brain.
If this is a brain, then we should not be.
No,
No,
We will stay. We will
No.
What is this?
Wait, this is a
Over section.
Oh wait. Of the abs. I don't. Wait, this is definitely.
With your
It's
answer.
abdomen. That's that's
That's pancreas.
So what is this?
It might be like.
It is. I don't know.
Guys, what's your answer? Okay, go ahead.
Alright. And final answer in 10 seconds. What is it?
Titus.
Yeah,
Pancreatitis? Okay, what's one possible cause?
alcohol.
Alcohol? Okay.
It's still on the wrong trigger.
Okay, it is a pancreatitis.
Alcohol, yeah.
We're so good.
Nice. Most commonly caused by gallstones and alcohol.
You're getting
Okay, someone else keeps someone like keep track of the score, but I think it's like 300 to 0, right?
I'm keeping score on the wall.
Okay, awesome, thanks. I think this first row go again since you got the answer.
Oh, it's still 500.
No, it's so hard.
Cardio 300.
Cardio 300.
I think we're cooked on this one.
Oh. Wait,
That's
surely
that's
that's
it.
intro paper.
No, that's not AFib. The regular, the rhythm is regular.
Because there's also.
Isn't it? Yeah, it's not.
Is it not?
No, if just, no, that's literally, it should be a plate. Wait, is that exponentially? No, it's not,
Wait,
no,
this
this
bottom?
FT has no.
Wait, it's not. It's
Oh, it
not
might
to be on AFib because AFib the pattern is irregular.
Okay, so we think it is then. AFib. Wait,
No.
hold on. Wait,
Is that final answer?
go. Wait, I think-
AFib.
AFib? Okay, so the answer is mitral stenosis. And I can go back. So AFib, like, yeah, the top, it does kind of look kind of jagged, but the main thing is like the rhythm is regular. You see P waves, it's a sinus rhythm, so it wouldn't be AFib. And the bottom, the main thing is like you see left atrial pressure is increased.
Here, no, that's a it's so hard.
So the bottom is showing pressure tracings between the left atrium and the left ventricle. So with mitral stenosis, since the mitral valve is like stenosed or damaged by rheumatic heart disease or whatnot, the pressure, you see the pressure kind of building up before it can actually overcome the ventricular pressure. Okay, so that's mitral stenosis. Okay, how about back to the back row? Neuro 300.
Oh. It's Eric, I didn't know you were on. Shut up.
Wait, okay, so.
I don't have syphilis.
Wait, let me.
I know you have syphilis.
Okay. Let's do this.
No, it's front versus back.
Bill, join us.
Wait, for
Join
like,
us.
wait, for advanced syphilis, it's just like the dorsal one, right? But it should be,
syphilis.
wait,
Arjun loves syphilis.
wait, okay, hold on. It should be the dorsal one, right? If it's in the lower. Yeah, wait, is it just? The dorsal one goes down.
All right, final answer.
Okay, the dorsal ones.
Dorsal, very good. Dorsal columns, this is called tabes dorsalis. With tertiary syphilis, it can affect the posterior spinal cord and cause things like loss of balance.
Wait, notably, we are kind of shit.
Okay, still back row.
It's gonna be all.
What?
Category.
Wait, no, they.
Okay, what category? You want to do Michelin? Okay, miscellaneous for 300. No, there's all
Mis-
water. I couldn't see it.
It said miscellaneous.
Miscellaneous. Okay, these are like not related to anatomy. They're just like
Oh.
okay.
Hymenoptera.
Hymenoptera.
you say that?
Yes, that's right.
We said it.
The front row.
Wait, Kevin got it.
Kevin got it. Kevin.
It's a lady at 100.
Okay, okay, you're not allowed to do miscellaneous twice in a row, or this is not fair.
No.
Wait,
It's LG 400.
Sorry, 400.
Come on. How was ours 300?
Wait, no, this is not what it looks like. This is notably not what it looks like.
Wait.
Also, a lot of these questions I pulled from previous practicals that I've written. So not the Pokemon ones, but some of the histology ones.
That we made it right.
Yeah, it's just it's technically not. What? If it's just like a bunch of it. No, if you know it's different. If you know what like
Five, 4, 3.
All right, final answer. 10 seconds.
They can see.
6, 5, 4, 3, 2, 1.
memory plan.
Mammary gland. This
Wait, can we try
is.
the question?
We tried the question.
Give me what?
Try the
Can we
question.
steal
Can
for
we
half?
steal for half?
I don't know. I don't remember how Jeopardy works. I think
Yeah.
if they get it wrong, I think you can steal, right?
Wait, my steal.
Okay, score.
If you get it wrong, if they get it wrong, it's
Okay, well it's not mammary gland. So what is first what I think?
ECT.
Yes.
PCT, what are the cells making it up?
Boy.
Okay. Yeah, PCT, Kapote, and Bellswater. Very nice.
So do they get full points or like 200?
I think they get full points, right? I don't know. Yeah, I think they get full points. Yeah. Okay. All right, first for front row.
It's still 500.
Go 100. No.
100. It's still 100.
100.
You're still 100. I think this is also from a past practical.
This is like, is this stuff?
This is
This is hard.
Yo.
Wait, is this
Are these like-
Wait, are these occipital cells in the parathyroid?
No,
No.
no.
This is not parathyroid. Is that a capillary? That's a
Capillary.
Wait, no, down there, capillary. Yo, guys, I think we're stupid. What is
Wait, like surely this.
Wait, salivary gland actually makes sense.
Okay, but what else?
Goblet cells.
Wait,
No,
those aren't
that's not
goblet
goblet cells. That is definitely not
Those
goblet
are not the.
But yeah, it's I. Is it?
No. But like the exocrine part is like the minority, so it wouldn't be.
Oh.
Like,
Wait, I
the
thought
part's
that-
definitely like.
What the hell is this?
Is
All right, 10 seconds.
pancreas.
What if it's?
Well, it's just like you can.
To say a cell, bro.
Wait, it says that salivary.
Salivary.
Cell.
Oh,
Wait, like
Yeah.
surely this is an acid.
like sheep cells.
Chief cells, no. Okay, back row, want to steal?
Yeah, it seems like. Wait, are these goblet cells? No. Wait.
10 seconds.
How are you seeing the board? Like,
Is this what they
Bro, why is 100 so much harder than the PCC one?
Say wait.
Hey, no, you're not allowed to.
No, I can't see.
You're
That's
actually
actually your problem.
Wait, these are not goblet cells.
Wow.
Goblet cells.
I
could tell. Wait,
Bro, oh my god.
I didn't know.
Who are you referring to?
Arjun.
Yeah,
I
I didn't know. What I'll say here.
Can we move on?
Wait.
All right, no. All right, 5 seconds. Give me an answer.
Okay, what? Like lymphocytes.
They said lymphocytes.
Yeah.
Lymphocytes. Okay, that was actually kind of close. It's eosinophils.
Oh.
So you see they're eosinophilic. They're red. This is eosinophilic colitis.
Wait.
They were completely credible.
Okay, I think it's back row now, right?
Wait. How about one more
I
round?
wanna do.
Okay, wait, let's do like.
Wait, just do.
Just do his still 500.
500.
His still 500.
Wait, just do a 500.
Okay, hit still 500, let's go.
So 500? All right.
Alright, bro, okay, well, let's get that, guys. I did, okay,
That is like.
okay, so one on the left, wait, I need to. What's this? Okay, so. Wait, no, the bottom right has like gaps between, in the myocardium. And then this one, wait, I can't tell what the bottom left is. The upper left is just Purkinje fibers. And then, this one over here is, wait, is it just like a random, wait, okay, the top right is like atherosclerosis. Yeah, just because it's a plaque. And then this one is like the Purkinje fibers on the top left. Right? Wait, is it you asked? I didn't say Purkinje. Okay. Wait, what is it? Is it just like inflamed? Wait, it's a block what? Wait, which one are you talking about? No, top left. Is what? Oh, yeah. Yeah, okay, wait, so top right is atherosclerosis, bottom left is fibrosis. Top left is like the Purkinje fibers. Wait, what? Yeah.
And then bottom right is like.
Bottom right? Wait, no, wait, it's just like gaps in the myocardium, so. Wait, I think it's like that, I think that's not there. What do you mean? No, they're just like, so it might even be, it might be.
All right. 5 seconds, 10 seconds.
Alright, just go with that. Okay, wait, what are we saying for top left? No, that's what they are. For, wait, this is just like. Wait.
The answer to 3.
Okay, wait, okay, so the top right is atherosclerosis, the bottom left is fibrosis, cystic fibrosis, and then the bottom. Fibrosis, and then the bottom right is myocardial infarction.
Wait, can we steal if they're wrong?
Yeah, you can still. That's
They didn't answer top left.
I think C is important.
Okay, so can we steal that?
yeah, you can still it.
Wait, C is not.
A might also be.
Wait, C looks so fibrotic.
Like D might is either black.
I think D is not. Wait.
It might be hypertrophy.
D is hypertrophy. Wait, looks fine.
No, what do you mean? No, it.
Feels fine to me.
Wait, what is A again?
No, they're like gaps in between.
Wait, they might just
Oh.
feel like an
Different types of. Maybe myopathy.
Wait, it might be.
Bro, I don't know.
Infection.
He has DMO.
Wait, aren't there two different types of?
Alright, answers.
All right.
Top left, pericarditis. Top right, atherosclerosis. C is myocardial infarction, and D is normal.
No, hypertrophy.
Okay. Not quite, but still pretty close. So top left is myocardial infarction. So you need that because there's a lot of, it's like a neutrophilic infiltrate, and you can see like it's called like wavy fibers, where it's like the dead and dying myocytes. Top right is atherosclerosis. You guys both got it. Bottom left is hypertrophic cardiomyopathy. So there is like a degree of fibrosis, but there's like myocardial hypertrophy, and it's kind of like in disarray. So this is thickening of like the interventricular septum, and then D is normal.
I thought.
Wait.
Yeah. And okay, so I think that's it. I'll have like I think Celia will send all the slides out if you want to look it over. And also she'll send out my contact information if you have questions about well, don't like, I mean, you don't need to text me questions about like the practical or anything, but if you have questions about like, pre-med or anything, feel free to reach out.
Okay, thank you.
Yep.
Thank you.